Good morning, students. So, we'll be going to study endometriosis. Another topic. Endometriosis is the presence of endometrial tissue outside the uterus. So, presence of endometrium outside the uterus most commonly consists of both endometrial glands and stroma, but rarely consist only of endometrial stroma. So, if you are getting endometrial glands and stroma outside the uterus, it is endometriosis. It occurs in following sites: ovaries, most common site, uterine ligaments, rectovaginal septum, cul-de-sac, pelvic peritoneum, large and small bowel and appendix, mucosa of cervix, vagina, fallopian tube, and even in laparotomy scars. So, how a patient of endometriosis present? She may present with infertility or dysmenorrhea, means painful menstruation, or pelvic pain. Endometriosis is a disease of women in active reproductive life. Most often occurs in third and fourth decade of life, affecting 10% of the women. So, theories behind the development of endometriosis. There are two theories. One is metastatic theory and other is metaplastic theory. So, metastatic theory, as you all know, metastasis. What is metastasis? Like in carcinomas, metastasis, here the endometrial tissue is implanted at abnormal location. So, metastatic theory behind the endometriosis. And metaplastic theory. In metaplastic theory, the endometrium arises directly from coelomic epithelium, from which the Mullerian ducts and ultimately the endometrium itself originate during the embryonic development. Clinical signs and symptoms are severe dysmenorrhea, dyspareunia, and pelvic pain due to intrapelvic bleeding and periuterine adhesions. Pain on defecation indicates endometriosis in rectal wall, means rectal wall is involved. If bladder is involved, endometriosis is in bladder, then dysuria may be the symptom. Intestinal disturbances may appear when the small intestine is affected. So, depending on the site involved where the endometrial tissue is present, the symptoms may appear. Menstrual irregularities are common and infertility is the presenting complaint in 30 to 40% of women. In addition, though uncommon, malignancies can develop in this setting, suggesting that endometriosis contains at-risk epithelium. So, malignancy can occur in endometriosis in rare cases. So morphologically, the foci of endometriosis respond to both extrinsic cycle and intrinsic hormonal stimulation with periodic bleeding. This produces nodules with red, blue to yellow-brown appearance on or just beneath the mucosal or serosal surfaces in the site of involvement. So, grossly, they appear as nodules, red, blue, or yellow brown, signs of hemorrhage beneath the mucosa or on the serosal aspects of the organ or site involved. When the disease is extensive, organizing hemorrhage causes extensive fibrinous adhesions. So, adhesion may be caused due to endometriosis, where between tubes, ovaries, and other structures and obliterate the pouch of Douglas. So, if adhesions are present between tubes, ovaries, it may lead to infertility. Ovaries may become markedly distorted by large cystic masses filled with brown fluid resulting from hemorrhage. So, if ovary is involved, means endometriosis is present in ovaries, then due to regular bleeding, the ovary may be enlarged, forming the large cystic masses containing hemorrhage. So, they are filled with brown fluid. So, they are referred as chocolate cysts or endometriomas. Chocolate cyst means endometriosis in ovary. The histologic diagnosis. So, this was the gross finding. On histology, endometriosis is usually straightforward. Straightforward how? If endometrial glands or stroma are seen, then endometriosis. But may be difficult in long-standing cases in which the endometrial tissue is obscured by the secondary fibrosis. In long-standing cases, we can find only fibrosis. A histological diagnosis of endometriosis is readily made when both endometrial gland and stroma are present, with or without the presence of hemosiderin. The hemosiderin is the pigment present in macrophages due to hemorrhage. In rare cases, only stroma is identified. However, if only glands are present, it must be distinguished from other entities such as endosalpingosis that have different clinical ramifications. Now, next terminology or next pathology is adenomyosis. So, adenomyosis. It is defined as presence of endometrial tissue within the uterine wall. Within the uterine wall, that is myometrium. Endometrial tissue in myometrium. And what was endometriosis? Endometrial tissue outside the uterus. And adenomyosis is endometrial tissue in the meiosis muscle, myometrium. Adenomyosis remains in continuity with the endometrium, presumably signifying downgrowth of endometrial tissue into and between the smooth muscle fascicles of the myometrium. It occurs in up to 20% of uteri. On microscopic examination, irregular nests of endometrial stroma with or without glands. Endometrial stroma with or without glands are arranged within the myometrium, separated from the basilis by at least 2 to 3 mm. So this is the gross picture of uterus, in which functional endometrial nests are present within the myometrium. These endometrial nests in the myometrium, producing foci of hemorrhagic cyst within the uterine wall. So clinical symptoms of adenomyosis are menometrorrhagia or irregular and heavy menses, colicky dysmenorrhea, dyspareunia, and pelvic pain. Symptoms are similar to endometriosis. So this is all about endometrium. So the main pathology of endometrium are endometrial hyperplasia, which we have studied, endometriosis, adenomyosis, and the normal cyclic changes, menstrual changes like its proliferative phase, how endometrium looks, and in secretory phase, what are the differences. So important topic for exam point of view. Thank you.